Hello, my name is Marilyn Harris, and thank you for joining me. This presentation summarizes my evidence-based practice proposal titled Medication Error, an Evidence-Based Practice Proposal. I'll be walking you through the major components of the project, which focuses on implementation of a standardized electronic medication error reporting system in outpatient settings. The goal is to reduce preventable harm and promote a culture of safety throughout better documentation, transparency, and accountability. Medication safety is a major concern in today's outpatient environment, where staff often manage complex treatment regimens under time pressure. Unlike hospitals, outpatient settings often lack consistent reporting structures, which allow errors to go unnoticed and unaddressed. This proposal is built around the idea of a structured technology-based reporting system, which can reduce risk by making it easier for clinicians to document and respond to medication errors as they occur. Currently, many outpatient clinics rely on verbal or informal reporting of medication errors. This creates significant gaps in documentation without reliable data. It's nearly impossible to identify patterns, perform root cause analysis, or educate staff effectively. These unreported errors can lead to adverse drug events, patient dissatisfaction, and avoidable hospitalizations. It's not just a data problem, it's a patient safety issue. So the intervention proposed here seeks to fill this gap of offering a structured, user-friendly way to report errors electronically, integrated directly into the electronic health records. My guiding clinical question was formed using the PICO framework. It's asked among pharmacists, physicians, and nurses in outpatient settings. How does the implementation of a standard medication error reporting system compare to no system in reducing medical errors and improving patient safety? To explore this, I focus on three research questions. First, how does this intervention influence the number of medication errors reported? How does it affect patient safety? How does it influence provider behavior? The literature clearly supports the need for better error tracking. Several studies, including Hodgkinson's, emphasize that prescribing and administering are most error-prone phases. Structured reporting combined with education and interprofessional collaboration significantly reduces error rates. Studies by Al-Harbi and colleagues and Muller also shown that technology-based solutions have a barcode scanning and reconciliation tools help close safety gaps. Overall, the literature justifies the integration of reporting tools that are embedded in the workflow and supports by ongoing staff training. The intervention is based on the Iowa model of evidence-based practice. This model was chosen because it emphasizes practical steps that align with quality improvement in real-world clinical settings. It begins with identifying a problem, here medication errors, then moving into teams formation, evidence review, pilot testing, and ongoing outcome evaluation. Using this model, we can ensure the project is not just implemented but sustained. It also promotes collaboration across disciplines, which is essential for long-term care. The solution is the implementation of a standard electronic medication error reporting system within the existing EHR. Key features include real-time alerts and documentation prompts, built-in medication reconciliation checks, required fields for error classification, and educational pop-ups or guidance when risky behaviors are detected. For example, if a high-risk drug is selected, the system may display guidelines or double-check prompts. These tools support both learning and accountability while encouraging providers to report errors without fear. Implementation will take place over 3 months. In month 1, the system will be customized to align the clinical workflow, and training will be delivered through workshops and printed guidelines. Month 2 will focus on pilot testing and select departments to collect feedback and troubleshoot issues. By month 3, systems will be rolled out across all outpatient departments. The key roles include a project lead to incorporate the work, an IT team for integration, and clinical educators to support staff. The estimated cost of implementation ranges from $8,500 to $14,500, which is relatively modest when considering the long-term reduction in risk and cost from adverse events. To evaluate success, we use a combination of quantitative and qualitative methods. Data will include the number and types of errors reported, staff surveys results, and safety indicators like adverse drug events. Focus groups and root cause analysis will provide insight into staff experience and system usability. Mixed methods analysis will validate findings. Evaluation will take place at baseline, 3 months, and 6 months, allowing for alternative improvements. Sharing the results of this project is essential for broader impact. Internally, findings will be communicated through dashboards, staff meetings, and newsletters. Externally, I plan to submit the results peer-reviewed journals, presented as professional conferences, and collaborate with patient safety organizations. This will promote wider adoption of the intervention. I've identified the ISPM National Medication Safety Summit as the most suitable professional venue for presenting this project. Unlike general conferences, ISMP especially targets medication safety, attracting decision makers, safety officers, and frontline clinicians. Presenting here increases the chance that the intervention model can be adopted or adapted in other outpatient settings. Remaining engaged in evidence-based practice is vital for professional growth and patient safety. I plan to stay current by attending conferences, reviewing new research, and participating in quality improvement initiatives. Incorporating fresh evidence into daily practice skills relevant and helps build a stronger safety culture. As healthcare workers, so must our approaches to problem solving. To wrap up, medication errors in outpatient allied health settings are preventable and represents a critical area for improvement. The proposed electronic reporting system is realistic, evidence-based, and aligned with current patient safety goals with strong planning, training, and evaluation. This intervention can reduce harm and support long-term quality improvement in outpatient care. These references reflect the scholarly research models and clinician tools that guided the development of this project. They form the foundation of the intervention's rationale and implementation framework.